all. This is Nurse 342, and our lecture this week is on collaboration, action, and narrative. Remember, we're talking about different ways of thinking, different ways of problem solving. So this week we'll focus on what's meant by collaborative decision making, and we're going to introduce this concept, but this is something that's discussed all throughout your reading assignments. We'll learn to express the value of collaboration in enhancing our clinical reasoning. We'll define the terms action and judgment and discuss how these concepts are related. And this also feeds into something called narrative reasoning, which you'll be learning about this week. We'll describe how assumptions influence our thinking and discern between different types of assumptions. This is something that's very difficult for people to do, to identify their assumptions, especially paradigmatic versus prescriptive and causal. Paradigmatic are very difficult to identify. We'll discuss the praxis of clinical appraisal and develop a sense for what we mean by the term impostorship. So let's get started. What do we mean by collaborative decision making? Well, oftentimes we think that it involves collaborating with other professionals, and it can mean that. It took me many years to realize that I should consult the clinical expert in any given area, when I have a real sticky problem. For example, when I'm having a client who's having difficulty breathing, it makes sense to call the respiratory therapist up on the phone and see what they think I should do about the dilemma, and then call the physician and ask them for an order for what the respiratory therapist recommends. Or, the same could hold true for a nutritional expert, a dietitian. When somebody's protein levels are low and we need a new diet change, to consult with them and then get a physician's order, or a nurse practitioner's order for that matter. However, we're not just talking about that here. We're talking about involving the client in decision making. I really think that we're moving in that direction. There's a lot of discussion over whether decisions should just be made by the prescriber, the main provider, whether it's the nurse practitioner, whether we should be authoritative about those decisions and say, and this is how it's been in the past. This is what I recommend for you. This is what you need to do. This is what I'm ordering, and you're going to do it. That's being authoritative in your decision making. Now, there's a lot of information out there, and you'll see it again and again in this course, where we should involve the patient in this decision making. So we need to take more of a holistic approach, collaborate with them, present all the options. And, there's times where collaborative decision making is an absolute must. And there's other times where maybe we do need to take a more authoritative stance. Maybe there's only one treatment for a particular type of rare aggressive cancer. That's when we're going to be more authoritative and say, this is your only option if you want to live. But see, that opens up another can of worms. Maybe an individual doesn't want to live encumbered with disability and illness. Maybe that's not the way they want to live and die. So anyhow, collaborative decision-making is decision-making between the clinician, the client, as opposed to the patient. Your textbook talks about how when we use the term patient, that we're being more, putting them in a lesser position than us. When we use the term client, they're more involved in their care, in the decision making, etc. So this is decision making between the clinician, client, relevant others, like the family members, for instance, and practitioners, which could be the nurse, the physicians, the therapists, etc. So this is one way to think, to remember to involve all these individuals when you're trying to make a decision. A decision should be shared. in most cases. So as I said, this is a hot issue. We're moving from, as your author says, scientific rationality and objectivity, from being a pure scientist and saying this is what absolutely needs to happen, to allowing patients to have some degree of self-determination in their decision making. So that's an important point that I wanted to make tonight. Collaborative decision making is very important as we use clinical thinking, as we reason through clinical problems. How can collaboration enhance clinical reasoning? Well, I just gave you an example with respiratory therapy, but if we're going to involve the patients, then we're going to come up with a decision and an outcome that works for them. I think I shared with you before, I cared for 2 elderly parents in my home over the last couple years, and toward the end, they really didn't want to live anymore, neither one of them. They were suffering terribly, and there are many times that we asked for a palliative care consult or, hinted to the fact that we really didn't want to do anything aggressive, and there are many times where that was ignored. So that's an example when someone's at the tail end of life and the treatment is very intrusive in making their diminishing the quality of their life. So we have to step back and really listen to our patients. Practitioners make numerous decisions every day about their patients. Sometimes they're small, sometimes they're big. So we have to learn to listen and respect our clients so that basically we can come up with the best outcome. We also need to respect their diversity. Their opinion may be very different from our own. And, in the end, are we providing proper care for them? And it doesn't always just mean eradication of disease. It means providing outcomes and decisions that they can feel comfortable with. So that's how collaboration can enhance clinical reasoning. And we need to do it. And we need to slow down. We need to listen to our clients. And this is hard to do in the chaos of the clinical environment today. So there's 2 elements, action and judgment, that are discussed in your readings. Action is actually described as the essence of clinical practice. We decide what the problem or the issue is that's involved. We have many, many issues every day, and we decide what we think the problem might be as related to what we're seeing. And then we take action, and we encourage our patients to take action. In our texts, of course, the authors are talking about clinical judgment of occupational therapists, physical therapists, nursing, physicians. We try to get our clients to act, and it might be trying to get them to walk down the hallway or rise from a chair. So we make decisions first about whether that action is appropriate for them. Are they ready to stand up? Are they ready to walk? So we make many professional judgments that are based on our observation of data, our interpretation of that data, and then we encourage action based on those judgments. So that's something that comes into play. Once more, these are thinking processes that we take for granted. But sometimes clinicians make improper judgments and recommend actions that may not be appropriate. So then we need to have a debate with each other. So that's action and judgment. Narrative reasoning. Think about those words for a moment. Kind of talking things out. Narrating is speaking, maybe even telling a story. And reasoning is thinking through a problem, thinking of all the parts of the problem. So narrative reasoning is actually a process that's taught to occupational therapists. And it's more than just telling stories. It's a kind of meaning making. You're trying to find the meaning in the story, in your patient's story, if you will. It concerns the relationship among motives, actions, and consequences. So, not just what are your motives as a clinician, but what are the motives of the patient? What does the patient want? What does the patient need? What are their perceptions of their wants and needs? And how are these positive? Are they going to lead to health and wholeness? So, we could actually sit down with the client and feed back to them what we see their story is. So, expert occupational therapists actually use this skill called narrative reasoning. It's taught to them, from what I understand, and they work throughout their professional lives to hone it so that they can get the story right. If they get the story right, then they can intervene appropriately. So I believe that we too, in nursing and all of the other disciplines, should work as OTs do to develop this skill. Now, there is an example of narrative reasoning in your textbook on page 60. It's called The Story of Anne. I want you to do all your readings this week, but definitely read through this story and the pages that follow to get a closer feel for what narrative reasoning is. Now, and we also use clinical reasoning skills. Clinical reasoning skills, I'm trying to find my page here. Please bear with me. Involve 3 skills. They are scanning, gathering, and appraisal. So think about, when you're, sorting through a clinical situation, a problematic situation, what could be even a small situation that you run into throughout the day. At the heart of clinical reasoning are these skills. And scanning is the initial sweep of the situation and circumstances. So in nursing, we talk a lot about data, subjective and objective data. So what are you seeing? What are the circumstances involved? What have you seen before? What's different about this circumstance? Is there something that's different, or are all the symptoms and data that you're seeing just like what you've seen before? For example, I had to learn what a patient looks like who is in pulmonary edema. They start out with some fine reels in their bases. If you don't do anything to correct the situation, they'll develop coarse crackles throughout their lungs. They'll become cyanotic. Their pulse oximetry, oxygen levels will drop, and they'll have air hunger. And if you give them Lasix or Bumix IV push, within 15 minutes, they start passing a lot of urine, and it remedies the situation. So I know that about pulmonary edema. But what if I went in and they also had something else like severe chest pain? That might be something different than I've seen before. Maybe their heart rate's low instead of high. I don't know. But there's some other piece of data that tells me, this is something that's different. So then you start gathering interpretive resources and data. Like, do you have protocols that you use on your unit regularly to manage pulmonary edema or chest pain or any other problem? Are there guidelines and policies in place to tell you what to do with this situation? Are there experienced staff members that you can draw upon their knowledge, textbooks, computer resources, etc.? So you're looking at resources at this point when you're gathering more data, really, and trying to make sense of what you're seeing. And then appraisal entails a critical review of multiple resources, which you decide which pieces of data to actually take action on or to do something with, or maybe it's to even report to the physician to see what orders they might have based on this key data. There'll be other data that you screen out, that you declare as irrelevant. So these are the three clinical reasoning skills that are reviewed in your readings this week, and they can be consciously taught to people, new practitioners. They can be taught to think, to scan, to gather, to appraise. And people don't even realize they're doing this. Once more, it's a part of our thinking that's taken for granted. But maybe if we teach practitioners up front when we're orienting them, we can even teach them about specific situations. What kind of data they might need to gather in such and such a situation. And it might help them in their clinical reasoning abilities. Behind all of our thinking are assumptions that are in play. And these assumptions, think about what that word means. These are just things that are taken for granted. Beliefs that we have about how all the pieces of life are fit together. And paradigmatic paradigm is a general belief system about how we think things work or how they do work. And you may have heard of paradigm shifts, where there's a major change in how we think. So if we moved completely away from authoritative decision making and always involved the patients or clients in every decision, and that became just the natural process of doing things, that would be a paradigm shift. So paradigmatic assumptions are assumptions that we really have a lesser handle or understanding of, because they're thoughts that we take for granted. So sometimes it's very difficult to identify paradigmatic assumptions. Another assumption is a prescriptive assumption. This is what we believe should be done in this or that situation. So we know with certain medical diagnoses like congestive heart failure, these patients definitely should have weights, ordered every day. And we should be checking those to make sure that there's not a weight gain. And if we don't, we're not following what should be happening. So as experienced nurses, we learn what should be happening in a clinical setting. And we see something else happening that's a little bit weird, maybe a practitioner that's acting in a strange way and not ordering things that are normally ordered in such and such a situation. We know that something's up. So prescriptive assumptions are our beliefs of what should happen. And causal assumptions are our beliefs of how one thing might lead to another. So we might have a general belief that if we're very kind and caring toward our patients, it's just an example that I just pulled out of my head right now. If we're caring and kind to other people, they'll be caring and kind to us. And that's not true, but we might have that general assumption. Or if we do something nice for someone, they'll do something nice for us later. And those aren't really clinical assumptions. Maybe we'll believe that if we're kind to our patients, they'll be more compliant. But they may have a psychiatric illness and they may be more trouble if we're really caring and kind, because they might be able to manipulate us then. So these causal assumptions are in play too. So we have to think about what assumptions might be going on in our reasoning process as we're trying to do some clinical reasoning, because some of these assumptions may not come to be. So the praxis of clinical appraisal, your author uses this term it's defined as a deeper analysis that we go through. So we use these clinical reasoning skills, scanning, gathering, and appraisal And we use these over and over again to work through different clinical situations. So this is a deeper analysis. We actually work to recognize and research the assumptions that are involved in our clinical practice. We consider our assumptions, and then we move through action, reflection on action, and then further action is actually this praxis of clinical appraisal. So we may pull all that data out, and we believe that we have a certain problem. Maybe it's a patient who has pulmonary edema, and then we give them maybe some Lasix or Bumix, and it doesn't work, and they're still having a lot of difficulty in breathing. So we'll reflect on what we've done. We might then reflect on some of the other data that we gathered or that we noted, and we take a different action or further action. We call the physician again and tell them that we're still having this problem. And so we keep reflecting and acting, reflecting and acting. And this is the praxis of clinical appraisal. So oftentimes we go through this with really sticky clinical problems. So as we use our clinical reasoning and think and practice, we want to get the whole team involved. When we have other team members involved, of course, it gives us more information, more data. And so they are involved with the scanning, gathering, and appraisal process. You'll present data maybe to the provider, and hopefully you have a good relationship with them, and you can say, well, what do you think about this? And they'll say, no, I don't think that's the problem at all, because with that problem, I also have noticed that the patient doesn't urinate or some other piece of data. And you're like, oh, I didn't think about that. So we're all going through this process of reasoning, and it helps to bounce some ideas off each other and to really listen to each other as well. But in the end, in clinical practice, the primary provider, has to make the ultimate decision. Other factors that come in play in the team is managing dysfunctional behavior. And your author suggests one way of managing dysfunctional behavior in clinical practice is to have some process in place where all team members can anonymously, let's say it's like a suggestion box. They can write down, who they're having problems with, what kind of problems they are. And then if the point person, let's say it's the manager of the unit, gets enough anonymous suggestions about trouble that they're having with one person, then you take that to that individual and you tell them, I've had all this feedback from your team members that you're yelling at them all the time, and it makes them very nervous and unable to get their work done properly after that happens, because they become very emotional or whatever the issue is. So actually confronting the individual who's being dysfunctional, and then the author makes no suggestion on what to do if the behavior continues, but I know what you need to do. If a team member is so dysfunctional that they're causing a lot of problems, they have to be let go, because this is a drain on everybody's ability to work. And then another issue that's brought up in your readings this week is the subject of impostership. I don't know if you've ever heard that term before, but there is a belief that we all suffer from this, and it's in our subconscious experience, and we don't realize that we experience this. An imposter is somebody who's pretending to be someone that they're not. So the idea is that we somehow feel that we don't belong or deserve to be where we are, and that we don't know anything at all, and that you have to pretend to be the person in the know. So you must admit that you at times feel like this, and you have to ask yourself, this is a very key question that your author poses. how does this impact my clinical thinking processes? Does it cause me to back down and not use myself fully as you're thinking, you're a tool in clinical practice, a good tool, hopefully. And how does impostership interfere with your ability to, for example, bounce ideas off the provider, whether it's the physician or the nurse practitioner? Are you being so timid and shy that you're not sharing what you know? So that certainly comes in play with clinical reasoning. So today I just tried to summarize some of the major points of learning this week. Certainly do your readings, and you will have a discussion board assignment that draws upon this theory. And I want to see you applying theory in your discussions. If you feel totally lost and you need any help at all, I'm always available to you. Contact me at cstiller@clarion.edu. So thank you all. Have a great week and enjoy your learning about thinking. Goodbye.